It's a great pleasure to be here. I must admit, it's also with a little bit of sadness, because over the years, I've aged relatively little, I believe, and seen some of my old colleagues. That's not the case for them. But in terms of speaking of age, if you follow the Twitter feed, it's a bunch of young folk tweeting about this, and Frank Harrell. That so much of what's wrong with medicine is we want to pretend we can just think of one dimension we care about at the time. Right now, we're thinking of quality. And we can't think of costs when we're talking about quality. We can't think of patient autonomy when we're talking about quality. And if you think that I am exaggerating, let's go through some quality measures that don't consider how expensive it is to get to these goals. They don't consider the heterogeneity amongst people. They don't talk about patient preferences. For most of these, me being fairly informed, I would refuse if these were free in most of the instances we strive for them in medicine. So underlying this heterogeneity effect is a lot of things of thinking about these two concepts, how much, and I think John Spiritus set this up very well, is that if we only think on the front end, getting the science right and informing clinicians, we will not get there. You need accountability and feedback, and you need tools to make it easier. How much heterogeneity? Yeah, just to look at this, this is this new finding from over 20 years ago of how much benefit there is from lowering blood sugar, right? And you see almost all the benefit in people with diabetes is getting them to 8%. The quality measure is all the importance of getting them below 7%. Most people with type 2 diabetes get almost no benefit from going to 8 to 7%. We've known this for over 20 years. It still has not changed, because if we let diabetologists write all the guidelines and quality measures, you know what? They don't have anything else other than blood sugar. And think what you're taking away from those poor people. If you say, blood sugar is not as important as you thought, because cardiovascular risk is what they die from, and blood pressure and lipids are much, much, much more important. Wish I was kidding. But even there's heterogeneity. Let's take the diabetics, right? And you look at the lowest decile and the highest decile for QALYs at risk. I'll come back to that concept. QALYs at risk is how much optimal treatment, right? It is, the lower bound is, of the treatments we have, if you employed all of them, you would get to zero QALYs that medicine can deal with, right? Instead of bounding it by, get it less than 7, even if we have no treatments that are safe and effective to achieve it. That's not quality, that's wishful and magical thinking. Well, when you deal with, and let's see if I can hit, yes, people at very high risk for blood pressure and diabetes, the SPRINT trial showed us what we already knew. This is from almost 10 years ago. We already knew that for people at very high risk, all the evidence from the clinical trials said, don't worry about blood pressure other than get them on 3, maybe 4 blood pressure medicines if tolerated. It's not how we're practicing, but that is grade A+ evidence. What your blood pressure is when you start a new medicine has almost no prediction on how much benefit you get from a blood pressure medicine. Grade A+. You look at the interaction from blood pressure and new treatment, and it's close to zero effect. Your blood pressure and your LDL do not modify treatment effects much at all, and it's what we base all our guidelines on. Now, you have somebody with the same blood pressure, but their overall risk is low. Once you have them on 1 or 2 medicine, you're close to doing net harm. We throw them all in one bin, and you know what? Even in these high-risk people, almost 50% will not reach that goal. You'll run out of medicines known to be safe and effective and pursue polypharmacy and not reach the goal. You've had lots of benefit, but our dumb quality measure is leading to dumb care. The same thing's true of lipids, right? Very, very high-risk people, many of them, PCSK9s make sense, right? It's a small group, but it does. That most people, moderate dose of atorvastatin, you're done, right? You'd have very little additional modified risk. Dilated eye exams just shows 12 years from publication of this it took to change the guideline, so that's fast. That we've been doing annual exams for all this time when we know pretty much the entire problem is not due to not having annual screening. It's surveillance of people with known disease who should have like 6-month follow-up, and they get lost because they're sick with other things. They miss appointments, we don't bring them in, and people that have virtually never been screened. We spend all our money in performance measure concentrating on wasting money and ignoring these individuals who do not really show up in your quality measurement. We are encouraging waste and harm with our performance measures because we do not understand heterogeneity of treatment effects, but also the multiple factors that go into it, issues of patient preference. We have autonomy. Now, you could make many equations. This is not the equation. This crowd would know that, but when I write for journals, they will pretend this is the magic equation. But usually to estimate an individual's net benefit, you have the relative risk reduction, which may or may not be different across your population. You have the risk of no treatment. That gives you the absolute risk reduction versus the absolute risk increase. This is pretty simple, and we don't think about it, and we don't help clinicians get this information. Everything else I showed you is just taking the best evidence on each of these 3 measures. So, instead of thinking about net benefit or net value as a dichotomy, and at what point do you recommend or not, we argue, look, it's a continuum. If you want to categorize things, at the very least, you would say, where is a point that the benefit is high? And across the spectrum of patient preferences, it's almost always high. Where is it that really it's very, very low value, maybe net harm? Where is the place that patient autonomy should reign? And make our quality measures with this. This is work, conceptual work done with Kerr, and I will try to mention all the different people that have worked on this, but probably fail. Simplistic dichotomous measures just don't make sense. They don't target and direct you and reward you for the people that benefit most. They don't help you optimize or do the right things. They ignore patient preferences, even though we tend to say that, well, patient autonomy and patient-centeredness is important, and it results in unintended consequences. Deselection of patients is often the best way to improve your measures. If they don't do what you tell them, or they're too sick, tell them, you're too sick for me, you should really see Dr. Spertus. Because he's an expert. And so Dr. Spertus is smart enough to say, no, you're best in Dr. Hayward's hands. And of course, waste is part of that, but the harm. And this is the paper we did a long time ago with Tim Hofer. I think Shelley Greenfield was the senior author on this paper, just showing that for A1C control, you could do so much more by deselecting your sickest 2 to 3 patients than you could by improving your care within the range that medical care affected it. So those performance overlords who always want to blame the frontline clinicians, and then you point this out and they say, oh, clinicians shouldn't do that. It says, well, you know, why not? You're giving them that incentive. Lenient dichotomous measures do one thing well. It targets the people that benefit most. But it doesn't promote optimal care. It doesn't take into account patient preferences, and it could direct all the effort being in those highest benefit people and leave a lot of benefit. In fact, Steve Goodman's point is here. If you draw the cut point too high, you are doing that. But you can draw the cut point at a more optimal place. Alternatives, by my count, I'm the 5th person to talk about Jeremy Sussman's work. The most impressive thing about young Jeremy is that none of us are quoting the same studies. And Eve Kerr, Tim Hofer, and Sandeep Vijan, and of course David, who goes without mentioning often. We would suggest that you must weight quality measures. Qualities is just one thing. You don't have to weight them by qualities, but we need to sort of not count everything the same. Something that's trivial and something very important being weighed the same is not sensible. You need to give more reward for getting that person with terrible blood sugar to 8% than getting the person 8% to 7% and punish the person who takes my poor old 80-year-old father and puts him on $150 a month medicine that has almost no safety data because his A1C is 7.4, right? So part of performance measurement should be overtreatment. It should be the person who's on more medicine that makes sense. Consider individual attributes that modify absolute risk reduction. That's the heterogeneity. Consider the effective, safe treatments that have not yet been deployed. If the person's on 4 blood pressure medicines at good doses, we have no idea if adding a 5th is harmful or beneficial. Having a quality measure that you get rewarded for implementing more treatment makes no sense. You have to consider partial credit, right? That, look, I have people refuse flu shots all the time, right? I'm in Ann Arbor. They're overeducated people that read Mother Jones magazine. And I'm okay with that. I push harder for those people that have bigger indications than others, and I do use a little guilt. If you get the flu, then an elderly person or child might die from catching it from you. Yeah, I'm devious when I really want somebody to do something like stop smoking. So if they're out here, I'm pushing differently than here, because it's continuous. And thinking along that continuum and the area of uncertainty is something we can do, and certainly John's shown it. I added this slide because of a question Frank Harold asked David Kent earlier about this continuum rather than quartiles. David and I agree pretty much 85 to 90% of the time, which is remarkable since our day-to-day variance in green with ourselves is probably only 90% at best. So once you attenuate for that, we agree most of the time. And so you can show people, and this, I didn't find the one I liked best. There was no red for this particular one, but you could have it dark red, lighter red. You have yellow in the preference sensitive, and the green can get darker. You can attach numbers here for those of us that like numbers, and you can show how much are they on the heavy benefit. The background could do all of that. This is not hard. Clinicians, we have found, appreciate this sort. They don't want pictograms with all of that information, primary care docs. Why? Because primary care is basically trying to take care of all the problems in a person's life in 12 minutes. If you sort of say, this is the first of 20 pictograms I'm going to show you, right, you are going to be thought as crazy and left. And there are a lot of decisions you need to make. So the big thing, the decision tool should at least find 3 groups, but they could show the gradation as well. That's easy for a patient and for a doctor to work, or a provider to work with that patient. You recommend when red or green, just like I do a flu shot and colon cancer screening, but strength of the recommendation can vary, and you respect the patient's veto. Some people have strong feelings, that's fine. I can tell you you're an ideal candidate for lung cancer screening. Person says, I smoke, I deal with it, I don't want the CT scan. I'm fine. But I don't start with shared decision making. The benefit is huge. And you just respect that because I have limited time with each patient, right? And that you can say the influential things. When people are in this yellow zone, right? You sort of say, I know from the model that they've developed, the influential thing. If you find it a hassle going to get a CT every year is high, it would make sense for you not to get lung cancer screening. If you would really regret missing a lung cancer and dying from it when it has a small chance of benefiting, then you should get it. And most people decide like that by telling them the influential things in our models that makes it preference sensitive. Okay, so, well, you'll have a copy of the slides, but here's how you can do it in a continuous measure. This is more work by Jeremy Sussman, and you can see the uncertainty. Here's the base case, and when it flips from net benefit to net harm, that's the preference sensitive zone. This is for aspirin, but you can develop this within the basis of evidence. So up here, I recommend an aspirin. Down here, I recommend against it. In here, I say, this is a tough call. But if you don't mind taking an aspirin a day, this could be reasonable because the main thing is not liking to take aspirin a day that would make this not a good deal. And that's because your risk is low and your benefit's low. Here's the same thing, preference sensitive zone. This is a paper Tanner-Caverly, published 3 days ago in Annals. And you notice that risk doesn't seem to do the job. Well, it's not just risk. When we considered risk plus life expectancy, all of a sudden we found 52% of the people eligible for lung cancer screening, there was no scenario where it was net harm. You could hate CT screening. You could double the false positive rate. It was always net benefit. And so those weren't that important. So with these 2 criteria, but you needed both, 10-year life expectancy and high risk, you could say, there, that's good. Here, highly influential, highly patient preference when either you have lower risk or a limited life expectancy. And this is not of all smokers. These are of all smokers eligible by CMS criteria. This is doable. But we have to have a performance management system. The measures need to run parallel with the decision support. The performance overlords, and I call them that affectionately, responsible, it's their responsibility for making these more sensitive, for managing optimal care. Don't let them off the hook. If they give us the tools and they make the measures responsible, then it's our fault. Until then, the over and underuse is their fault. Many important aspects of medical care cannot be measured. And I'm going to end on this slide, that there are cooperative approaches in which the heterogeneity of effects should be weighed by a caring professional. Things like end-of-life care. That should be part of us, but part of that is allowing individuals to tailor that. If we use these statistical models in areas where they don't work, we will be doing a disservice. if we don't encourage cooperative quality important for things that are critically important, right, but not as quantifiable, that's on us as well. Michigan Blue Cross Blue Shield has been a pioneer in this sort of area, in which the measurement, they tailor the nature of the quality improvement initiative to how good the quantitative data are. Sometimes it's a summative eval. Sometimes it's formative eval to go in for QI. Sometimes it's solely used for QI. Most providers are dedicated to doing right if you could convince them that they're right, excepting probably cardiologists who already know inherently what's right and wrong. But for the rest of us, we're trying to do right, and we need to make it easier and hold accountable the bad actors. So thank you.